Dr. Ali, and we are going to continue in our interesting psychiatry lectures. Today, we're going to talk about eating disorder. Before we start, Bismillah ar-Rahman ar-Rahim. Uh, can you hear me well, or should I raise my voice, or it's okay?
It's perfect.
Perfect. Okay. So an illness we're going to talk about today is eating disorder. It's affect about 3% of the population. A study in America found that almost 3% of people have eating disorder. So it's very, very quite common in the world. Why we eat food? Food is part of our surviving system. When God sent us to earth, cannot survive without food. So food is very essential for our survival. That's why it's controlled what we call by the midbrain. The midbrain, if you remember from the lectures on addiction, is the part of the brain that control our basic need like sexual activities, food, and willing to survive. Food is very delicious, and as we said, if you don't believe me, ask the dishes, as they say in Disney. Food is not only essential, but it also causes joyful. And the word joyful means happiness is because it increased dopamine in the part of the brain that is part of the reward system, which is called the pleasure center in the brain, which is combination of nucleus accumbens and ventral striatum. This, the two part here, is the pleasure center of the brain. And anything that increase dopamine in this area of the brain becomes so essential and so important in our life, and we rely on it to survive for survival. As you see here, food will increase dopamine from 100 like to 200, 300. It's depend on the food. So that's why we are addicted to food, or it's part of our survival, part of our reward system. So food make us happy, make us survive, make us, normal in life. The problem with eating disorder, so eating is not a disorder, is an order, it's part of life. But some people might have what we call eating disorder. So we're going to talk about this eating disorder. It's more common in female. So eating disorder is more common in female, although male also have eating disorder, but it's a little bit more common in female. The reason for that is very complicated. It's biological and it's social and it's the media. So society promote people to be thin as successful people, and that was put in our unconscious mind from the media and from the TV, from the models. There is peer pressure, so everybody, when they look at you, oh, you lost some weight, so it's kind of like good things to hear from people that you lost weight. That's mean losing weight. That's mean you are strong. You have good ability to control yourself. And people start looking at overweight people as a negative way. In negative ways, that's why it might affect the female, as they are much more sensitive to weight gain and to their appearance. In fact, women tend to viewed by society through their bodies. So when men look at women, they don't look at her brain or their intelligence. They first look at the features of that woman. So they are judged by our society through their bodies in our eye contact. Women, on the other hand, are more pragmatic. They look at man more. I mean, they look at the body also, but they look more about the frontal lobe. The frontal lobe is our personality, our achievement. So women want someone to have good brain so he can help her raise her kids and her family. So she is more concerned about the achievement of the male rather than the appearance. But male is more concerned about the appearance than the achievement, and that what put pressure on female in general uh, to always look great. And part of the culture that part of being in great look is to be a little bit thin, not overweight. And that's the pressure that's put on the woman here. Psychodynamic view, they look at eating as a part of communication. So mother-daughter conflict sometimes can manifest by food. That's why always, like when you meet somebody, we always invite him to eat together. Let's have coffee together. Let's have food together. It's part of love. So when you eat with someone, is part of communication, part of being loved, and part of providing love for that person. Most likely we're going to see in the illness of eating disorder that most these patients who had eating disorder, they have several things in common. One of them is most of them have low self-esteem, and they might be looking to be perfect, and that's what caused them to be in this pendulum of being thin and eating and all of these complications. So they might also have something we call feeling helpless, as they cannot control their ability to control food, and they feel the power in eating, so they feel powerless without eating sometime. Sometimes food and hunger can be a way to escape reality. So a lot of women will have eating disorder because when you stop eating, you lose weight and you lose your menstrual cycle in women. And sometimes women use that as a defense, or and they don't want to be an adult. They just feel like they want to stay in the childhood phase. So when they lose their menstrual period, they feel like they don't want to grow up and face the reality of tough life at some point. So it's very, very complicated. Most of them will have, we said, low self-esteem, conflict relation with parents, and their personality is usually shy and inverted and sometimes very anxious. Let's take the first case, and this is a case happened in my clinic about 10 years ago. I was just coming here, and one of the doctor who was rotating with me, she's a family doctor. Her name is Dr. Noor. And Dr. Noor, during her rotation with me, she said, Dr. Ali, please, would you please help me? I said, what? She said, I think my daughter have depression. I said, how old is your daughter? She said, she's 3 years old. I said, how come she has depression? She said, my daughter is refusing to eat with me and refusing to dress with me. And every time I approach her, she is refusing to even eat when I try to eat with her. So can you please help me? And when I look at the dynamic of the situation here, I always look at the root of the problem. I don't think the daughter has depression. What we found out that she is very busy resident. She was second year resident in family medicine, very, very busy schedule. And her husband is a surgeon. And this is a message for all of you, male and female here. So she's a physician resident, very busy. You know how residency schedule, day and night and shift, and no time for family. And her husband even in a worse situation where he's a surgeon, that he doesn't have even time to be with the daughter. So the daughter stayed most of the time شغالة with the helper, and the daughter is very unhappy about that. But as you remember, when you are 3 years old, you cannot express your emotion, because expressing of the emotion require you to have very good frontal lobe, and as a 3 years old, she doesn't have well frontal lobe to express those emotions. So she expressed it by refusing to eat with her mom. So food can be a way to communicate here. Of course, the solution, I told Dr. Noor to take a 6-month vacation and get connected with her daughter, because her daughter is upset about not being able to bond with the mother. And the problem we're gonna know in child psychiatry is if you don't bond with your kids at early age, you will never be able to bond with him again. So there is a very critical window between age 1 and 3. If you don't bond by this age, it will be very difficult for you to bond with the daughter again, and that is one of the complication of daily life. So always put your family first. I told her take 6 month vacation without pay, and get connected to your daughter, because if you don't bond with this daughter now, you will never be able to bond with her again. And I told her this is not depression, this is a form of conflict, that your daughter is unable to express that feeling to you, because she doesn't have a frontal lobe to translate those feeling or those emotion. So that we're gonna talk about three disorders: anorexia nervosa, bulimia nervosa, and binge eating disorder. The first lectures will be about anorexia nervosa, and this is a typical feature of a patient with severe anorexia. They are very common even in our society here, and they require a lot of help, and they have very grim prognosis, most of them. So anorexia came from the word, the Greek word, loss of appetite, and nervosa means loss of appetite due to emotional reasons. So that's where the word came from. Uh, in cognitive behavioral model, these patients have fear of being fat, and they have disturbance in the body image. So even though this lady, the one we saw here, she feel like she is overweight. Even at this point, she feel like she's overweight. So they look at themselves as very thin and extremely overweight. They can lead, this can lead to extreme dieting. So I remember one of my patients, she eat like one piece of a cracker. She measured it with the inches, like 2 3 centimeter of that piece of cracker every day. Or they eat half a grape. I remember all these stories. Like one of my patients eat like, cut the grape in 4 pieces and eat like one quarter for lunch and quarter for dinner. So they are very obsessed. They view weight loss as a form of self-control. So they are very unhappy about the way they look, and they want to become thinner and thinner. And it's always, controlled by the media and the peer pressures and all of that. As we said before, this can be a defense against puberty. So a lot of the patient with eating disorder might have been sexually abused as a child. So part of being thin and part of not being able to grow and not having menstrual cycle, that I don't want to be a female, I want to stay as a child because I don't want to be subject to sexual harassment by men. So this is very common reason unconsciously for that problems. There is two kind of eating disorder in anorexia. There is the restrictive and the purging type. So some of them will be restricted, and they eat like this tiny little piece of things, and they control their diet carefully. Some of them will eat a little bit more, but they compensate by vomiting and using laxative and using diuretic and excessive exercise to stay very thin. The requirement for the diagnosis is to have a BMI of 18 or less. So if you are 18, you are probably in the verge of being anorexic. Of course, way below 18 will be considered severe anorexia nervosa. Like if you are 10 or 11, this is what we call extreme anorexia nervosa. They compensate, as we said, by vomiting or drug abuse, like they might use a lot of stimulant, laxative, self-induced vomiting. Most of them will have depression. They are socially isolated. They have comorbid insomnia. They can be irritable. They have no interest in sexual activities, and they might have problem in the reward system in the nucleus accumbens. So they will not get married or and don't enjoy food at all. So food, which is a form of enjoyment to us, it does not give them any pleasure because it could be problem in the hypothalamus or the nucleus accumbens. So the requirement for diagnosis is refusal to maintain body weight and fear of gaining weight. So the main idea is for them to stay below the 40 kilogram or the 30 kilogram weight. They deny that they have a problem, so they don't have any insight. So even though they look very thin, they think they are overweight. And also, one of the important part of diagnosis is they have amenorrhea, so they will not have their menstrual cycle for at least 3 times. If you meet this criteria, then you will consider be anorexic. The low BMI, the fear of gaining weight, the lack of insight, and in the menstrual cycle cessation. I will. There is a new article last week about the refusal. They said they don't refuse to gain weight; they just unable to gain weight. So the old think we thought that they just don't want to gain weight, but the idea now and the new study show they really want to gain weight unconsciously, but they cannot do it. They are unable to maintain the weight gain. So that's why anorexia now consider a misnomer. Means it does not technically involve loss of appetite. I mean, the patient will tell you, I want to eat. But it's anxiety and obsession about the weight and the inability to enjoy that food. And the food sometimes make them anxious. How come it make them anxious? Well, it make me happy when I see the falafel and the fool. I become very joyful. Anytime you see biryani, you just feel so great. The reason is for normal people like you and me, dopamine in the nucleus accumbens and the striatum make us happy. That's we said. But for the anorexic people, it does not make them happy. It made them more anxious, more depressed, more painful. So that's the idea. What make us happy, normal people, it does not make them happy. So there is not only social and psychological problem, it's more like biological problem and the reward system in the brain where the food does not make them does not give them any sense of pleasure. Instead, it make them very anxious. That's why they don't want to eat sometime. So the striatum, as we said, is the critical component of the reward system. It's part of the nucleus accumbens. It's received the input from the ventral tegmental area, and those patients who suffer from anorexia, dopamine release in this area sometimes does not give them any pleasure. In fact, sometimes it gives them some painful feeling and some anxiety. So this is the way to look at it here. You see here the over activities in the limbics, in the dopamine in this area of the basal ganglia and the nucleus accumbens, which make us very happy. It made them extremely anxious and very frustrated. So there are certain characteristics of these patients. They tend mostly to have low self-esteem, low self-evaluation. They have what we call self-loathing. In Arabic, we call it jald that. They don't like themselves. They come from very competitive, high achieving families. So their family always looking at them and said, you need to be thin, you need to do this, you need, they just put a lot of pressure on them. You need to have A plus in the exam. You need always to pass all of the, you know, lectures with a very high grade. They set perfectionist standard in the family. They are very strict family. Have genetic components. So most of these cases are usually genetically inherited. The culture play a major role. So our culture will promote thinness with this model on you see in the TV where they are very, very thin and very slim. They idealize those ideas. So the media play a major role in this. They feel ashamed, most of them dissatisfied in life, and they don't like their own body because their family did not give them the love they need, and they did not accept them as they are. So they have no emotion usually. You look at them, they are flat. They don't have any ability to love and be loved. They are just feel like a piece of furniture at home. They have distorted body image. So even though they are very thin, they look at themselves as very fat, bad attention span. They are very obsessed with food. Like I told you, this lady who cut the grape in 4 pieces and eat one quarter of a grape every day. Uh, they have very tends to be high achiever, and they have no interest in any activities except obsession with food and other issues. It usually starts around 14 to 18 years old. We said 90% are female. We do see it in male, but to much lower extent. Hospitalization is always required, so most of them might require hospitalization, and the prognosis is not very really great because the illness tend to relapse. It relapse usually with the stress. Any stress can make them relapse. Death rate is 10 times more likely to with other illness, so they have very high mortality rate. And we said one of the genetic factors, like if you have the gene for anorexia, it doesn't mean that you're going to develop it. It's more than gene and environment, as we said. So for example, if you have the gene and you have very restricted family and society who promote thinness, then you might develop the illness. One of the area beside the media and the family criticism is when if your mother, when she was pregnant with you, have severe diet, like we said it's inherited. So part of the brain that is responsible for the eating and the hunger is called lateral hypothalamus. This is the hypothalamus here, as you can see it. This the one in orange is the hypothalamus, and usually there is the lateral hypothalamus is the part of the hypothalamus that control our appetite and our hunger. So they might have a problem in that part of the brain. So if your mother did not eat well and was strictly dieting during pregnancy, the part of the brain that's responsible for you to develop hunger feeling might not develop, and you become hungry. Impact of the media, we said 90% of the girls, usually age 33 to 11, have Barbie. And Barbie usually promote thinness because she is very, very thin. So if Barbie were a real woman, she will measure 38, 18, and 33. I don't know this number myself, but if you are a woman, I'm sure you know what is this. That's mean they are. Barbie is very, very thin, and only 5% of the female can be like Barbie because it is not the natural domain. So when they put pressure on you from childhood, from early childhood, that you're going to be like Barbie, then you're going to face this problem all the time. So in the 60s, the figure of woman was much thinner, much thicker. So until the 60s, before something happened in the media, they used to promote women, healthy women, as a little bit more fat and a little bit more what you call full of curve, and that's usually most men like women like this, but the media is the one that triggered those feeling in women and change the uh, culture and change the unconscious mind, the collective unconscious mind of these women. Usually anorexia always have coexisting illness. For example, you see it a lot in borderline personality, depression, anxiety, obsessive compulsive disorder, post-traumatic stress disorder, and substance abuse. Most of them will develop eating disorder after being sexually abused or exposed to a lot of stress in their life. So this is something to worry about. So one of the features, we say they have distorted feeling about themselves, the lack of insight. Even though they are very thin, this lady look at herself as very, very obese, despite the fact that she is very thin. Fear of gaining weight is the main issues. That's why they measure their weight in the milligram, if you want to say. And they always have distortion in the way they look at themselves because of the media and because what we put in their unconscious mind from early childhood. There is a lot of consequences for anorexia. Most of it is going to be the kidney. Severe dehydration can lead to kidney failure, inability to concentrate the urine, free water loss, hyponatremia, GFR will depleted and be low, and that will eventually damage the kidney. You might see some kind of skin lesion like called lanugo, which is a tiny little bit of hair on their bodies as an evidence of severe eating disorder. Their bones will be brittle and they might expose to osteopenia and they will have a lot of fractures. Their muscles are very weak and very they might have a lot of pain related to that, low bone density. They definitely have low estrogen and high cortisol level, and they have high osteoporosis level. So it's very, very complicated illness. They definitely, one of the requirement for diagnosis is having no menstrual cycle, because when you lose a lot of weight, then you will not be able to have any menstrual cycle. So if you lose a 3 menstrual cycle and not during pregnancy, then it will be considered part of the diagnosis criteria of anorexia. As we said, they will have bone marrow suppression, anemia, leukopenia, thrombocytopenia. They have low sexual hormones, low growth hormone, so they don't get bigger, and they have a lot of you know, deficiency in a lot of these hormone through the adrenal and the hypothalamus tract. Starvation usually can cause muscle loss. And when you lose muscle, your creatinine will become low, you become fatigued. One of the muscles in your body is the diaphragm. So if you lose muscle in the diaphragm, then you will have difficulty breathing. So this is one of the common complication of the anorexia is they don't breathe well because their diaphragm muscle is very weak because of low muscle mass. On the heart is really where most patients die from heart failure, because when you lose the heart muscles, you will have a bradycardia, so their pulse is very low. They have hypotension, very, very low uh, blood pressure. They have orthostatic hypotension, so that when they sit and will stand up, they feel dizzy and fall down. So this is also sign of anorexia, plus the dehydration can cause orthostatic hypotension. Also, they will develop congestive heart failure because of lack of the muscle power. Congestive heart failure with low creatinine and low protein will end up having edema in the feet. So when you see the patient with edema, it's part of the anorexia because of lack of proteins and because of the congestive heart failure. The combination will cause this problem. And as we said here, most of the fatality happen because of a cardiac problem. Uh, so in the clinical manifestation of anorexia, treatment should be always trying to restore body weight, trying to change the image. Psychotherapy will help with that, and addressing the psychosocial family issues. So one of the things that we need to talk to the family to make them less what you call accusing, less restrictive, more able to communicate between one another, and try to improve communication with the family member. So it requires a lot of treatment. It requires psychiatrists, psychologists, social worker, and dietitian to help them go through this in inpatient setting usually. Usually we need like nutritional rehabilitation, psychotherapy. Medication will also help. We're going to talk about certain medications. So most of them will go to what we call eating disorder hospitals. So there is several eating disorder program in the state. I think in Riyadh we don't have anyone yet, but I'm sure they will have in the future. So we send them to inpatient treatment. They will stay like for 30 days. During the 30 days, they will take medication, will have family therapy, will have cognitive behavioral therapy, try to change their feeling. The two medication we use mostly is fluoxetine, Prozac. Fluoxetine works in some cases. It doesn't work on all the cases. So there is subtype of anorexia, which is some of them like the weight restored patient might work, but if they are not waitress, it work when the patient get out of the wood. So if they start to improving, then fluoxetine prevent relapse. So that's why they use it, but it might not work during the acute phase. Also, olanzapine, Zyprexa is one of the medication that increase your hunger. Like if I take Zyprexa myself, I will gain 20 pounds or 20 kilos in 1 year. Zyprexa is one of the medication, or olanzapine is one of the medication that make you hungry all the time. So because it decreases the sense of fullness in the stomach, so it will promote your hypothalamus to keep hungry all the time. That's why we don't use it for bipolar much or for schizophrenia, although it's approved for that, because most patients, if you remember, they will gain a lot of weight on it. But unfortunately, for the anorexia, it might not work as good, but it helps with some cases. So olanzapine is one of the antipsychotic that we use off-label to help patient gain weight because it increases hunger through activation the hypothalamus hunger center. Refeeding syndrome, this is very, very important to know. When we start feeding the patient, we have to be very slow and very careful. Why? Because these patients, to start with, they have very low potassium, very low magnesium, and very low phosphate. So when we feed them quickly, refeeding, when we do a lot of food, they will have increase in insulin secretion. Insulin secretion will deplete more of these phosphate and magnesium and potassium. When you deplete those, you put yourself at risk of arrhythmia, and most patients die of cardiac problem. So the bottom line here is refeeding is important, but it has to be done by very, very good psychiatrist and very good nutritionist. And the food should be started very slowly, so we don't deplete their phosphate and magnesium and potassium, because decreasing those more might put the patient of cardiac arrest. In psychotherapy, we always CBT help the patient in moving from the rigid thinking. Most when you work with eating disorder patient, you're gonna notice that they have very strict thinking. They are very hard to argue with them. I have very hard time arguing with them. Like, can you eat a whole grape instead of one quarter of a grape? They are very strict. Things about food and weight gain. So in psychotherapy, we try to change their mind to be more flexible and accept the change and accept the other fact, and improve their insight about their weight and their life. As we said, the prognosis is still not the great. 30% will die either with suicide or cardiac arrest or malnutrition. Uh, Recovery is 40%, and 30% will continue in milder course of the disease. Now we'll move to the next illness, which is bulimia nervosa, which is a very common illness also. It came from the Greek word. Bulimia means ravenous hunger or extreme hunger, if you want to say it in Arabic. Or in English, it's mean extreme hunger. The characteristic of patient with anorexia, always they have very low self-esteem. They are very fixated on food. They desire, they like to control their body, and desire to control their image. They usually start in adolescent, like somebody fail in the exam, for example. That trigger a lot of emotion. A part of this emotion, they compensate that they cannot control their exam, so they're going to control their food. They start using laxative, stimulant. It's usually always commonly coexist with anxiety, depression, post-traumatic disorder, stress disorder, and substance abuse. Very common in those patients. Usually occur in female more than male. Uh, Start in adolescent, as we said, and adolescent, and also it can have another peak in the 40s. So both of them will have, in the 40s we go through midlife crisis, and we want to be teenager again. So we might promote thinness at that time, and want to be very thin due to that reason. It's begin when you diet and you fail in your diet, so you compensate by vomiting and using laxative to control your body. So you have huge appetite, but you don't like your body, so you want to keep eating and then purge what you eat to stabilize your weight. A majority of them have depression, have a lot of dental problem. Vomiting cause a lot of electrolyte imbalance, and the acidity of the stomach will destroy uh, your dental part of the mouth, and that's very bad. Bulimia also occur in nervosa, so anorexia. So they might be anorexic at some time, and they move to be bulimic at some point. So one of the characteristic of the family and those patients, they have what we call enmeshment. Enmeshment means is when you lack, when there is no clear boundary in the family member. So you look at them, and the parents talk about their feelings, so they don't have any feeling left. Their parent will talk on behalf of them. So the boundary in the family is very blurred, very weak boundaries. They are melt in the family. Their family also overprotective, very rigid, and they have a lot of conflict in the family without any resolution. So that will tell us that treatment of the family as a whole is very important in treatment of bulimia. Bulimia's treatment is also involve the family and the patient to try to clarify these issues with the enmeshment in the family. They usually go in the vicious cycle. They binge eat. They feel guilty about the eating. So they self-induce vomiting. They feel hungry again. They eat again and they induce vomiting and they go on this vicious cycle. In the physical exam, you notice that they have very low self-esteem because the family look at them as their figure and they might not like the way they look. So they become, they have very low self-esteem because they feel a little bit fat and our society promote thinness. So when you are overweight, then you are not liked by other, and you cannot validate your feeling, and nobody will look at you in a nice way when you are in overweight situation. So this self-esteem is very important. They have trouble controlling their appetite. So we said that when our frontal lobe is weak, then he cannot control the limbic system where the food appetite is and the desire for food in the reward system. So we're going to keep eating because our frontal lobe is unable to inhibit the reward system. So that's why we said part of the illness is when you have poor relation with your mother, or when you have abusive childhood, or when you don't have any connection with your mother. Because you remember, connection with the mother is what make your orbitofrontal cortex stronger. And we said orbitofrontal cortex is a part of the brain that control your appetite and limbic system. That put you at risk of addiction, and addiction to food is part of the addiction. So the family may have higher than usual incident of childhood obesity. So most likely you're going to have a sibling who is obese. They have negative self-evaluation. They have a lot of criticism. And remember, we said in the first lecture, don't criticize anybody and always blame the chicken. Don't blame the person. And you might have sexual abuse as a child. So sexual abuse can promote or can cause eating disorder always. Most of these patients who had severe eating disorder might have sexual abuse as a child. And we said you should not be accusing or criticizing anyone. So part of the treatment is to teach the family how to change the attitude and resolve the sexual abuse issues by doing some kind of therapy or hypnosis. Biologically, these patients might have lack of serotonin. You remember, serotonin is made from a amino acid called tryptophan. So when you eat carb or when you eat bread, it turns into amino acid called tryptophan. Tryptophan is the father of serotonin. So tryptophan goes and with magnesium and calcium and iron and folic acid, it will transfer it into serotonin. Serotonin also go in to make melatonin. So most of these patients with anorexia have low serotonin. When you have low serotonin, you're going to crave carbohydrate because the only way to replace serotonin is to eat something with carbohydrate, because carbohydrate have tryptophan in them. So that's why low serotonin make you hungry and make you unable to sleep. That's why we need to eat and replace that serotonin by craving carbohydrate. So always when we see somebody craving a lot of carbohydrate, that's mean they are very stressful and they don't have enough serotonin, and that's why they crave this carbohydrate. So low serotonin level is one of the features of patient with bulimia. And we said when we are emotional, we decrease our serotonin. Remember from the first lecture, we said serotonin, a neurotransmitter that is released when we are relaxed and calm. So if we are stressful, we stop releasing serotonin. So we need to replace serotonin by eating a lot of food which has serotonin. And that what put us in risk of obesity and bulimia. So when you are low in the serotonin, you're going to be at risk of bulimia because you're going to compensate by eating a lot of food which has tryptophan, and tryptophan is available in the carbohydrate. And then you compensate by vomiting because you don't like the way you look, and you compensate by vomiting. So one of the problem with the vomiting is three things. You're going to have kidney failure because of hypokalemia. You're going to have cloudy thinking because also of low magnesium and low potassium and low phosphate, and you're going to have arrhythmia. So this is the three complication of the vomiting. Frequent vomiting cause all of these: kidney failure, heart arrhythmia, and cloudy thinking. It also affects your teeth because of the acid in the stomach. When it goes to the mouth, it will affect the enamel of your teeth and cause like erosion of the dental enamels and tooth decays. Frequent vomiting will cause your adrenal, will cause your adenosis to be swollen. So this is one of the common. You will have halitosis, very bad mouth of smell because of the vomiting, frequent vomiting. Now, Russell sign is the thing we see on the hand because of the induced vomiting. So we look at what you call Russell signs, although most patient now is using different instrument like a toothbrush to induce vomiting. Frequent vomiting also cause sometimes rupture of the stomach, rupture of the stomach esophagus connection, and sometimes rupture of the esophagus itself, called Miller-Weiss syndrome. Also cause severe constipation. Constipation is one of the consequences of using a lot of laxative. Diagnosis is always patient will binge and purge, binge and purge. So they eat and then use laxative and to prevent them from overweight. So some people might confuse that with anorexia, but anorexia is always underweight. But binge eating is always you are normal weight or overweight. So this is the difference. Anorexia, when because both of them will do the same thing, restrict diet and restrict eating. But in anorexia, they might just not eat, or when they eat, they purge and they keep very, very underweight. Well, in bulimia, they might be normal weight. It always related to stressful life events. So most of bulimic patients might be normal, but when they are stressed out, we said they stop secreting serotonin, and they want to replace that serotonin by eating carbohydrate. When they eat carbohydrate, they become fat. They compensate by vomiting and purging. So we have this DSM-5 criteria: recurrent episode of binge eating, which is characteristic by eating for 2 hours, a large amount of food. They cannot control their eating, so their sense of control is impaired. They cannot. They want to eat one hamburger, they eat 5 hamburgers with a lot of fries, and they cannot control that urge. And they compensate by using laxative. So they eat this huge meal and they go to the bathroom and start vomiting and using laxative. And usually it occurs at least twice a week for 3 months. They have very obsession with their body weight and body shape. And it does not occur during anorexia. So we said anorexia is different illness. They always obsessed with low calorie diet sometime, and they are within normal weight. So if they are way below the normal weight, they are anorexic. So the difference again, but because this is very important to differentiate. So bulimia is always a trigger by environmental stress. Any stress can trigger that because of low serotonin. We said if you are way underweight, you don't have a menstrual cycle, it's most likely anorexia. Bulimic patients usually have normal weight or overweight, and they have their menstrual cycle, but the other features are almost the same. In other description is anorexic patients are introverted. They are not overcoming. They keep themselves. Where bulimic patients are extroverted, so they like to talk and have friend and have a lot of emotional feeling. In anorexia, the food is comforting, so that when they eat, they feel great. While we said in anorexia, the food is causing painful feeling. So anorexia food make you more painful and make you more anxious. In bulimia, food will make you happy, like most of us. Preoccupation with losing weight, and here is preoccupation with the ideal weight. So they know they are able to eat. And treatment of bulimia is very, very interesting. You have to involve the whole family. You have to tailor a plan for each family. You have to talk to the family, nutrition education, family education, hospitalization, medication. Usually the medication we use for bulimia, the only one that is having usually having problem or having having what we call uh, the medication that have indication is Prozac also. So Prozac is one because Prozac increase serotonin. Remember, SSRIs increase serotonin. So any SSRIs will help because they increase serotonin in the blood. There is a caution always come in the exam that you should not use a medication called Wellbutrin. Wellbutrin or bupropion is an antidepressant, but it's contraindication in bulimia because it can induce seizure on those patients. So this medication is although an antidepressant, but it doesn't increase serotonin. It work on the norepinephrine. So this medication is contraindicated in bulimia. Remember, it's contraindicated in bulimia because it might induce seizure in those patients. Now we'll move to the last session is binge eating disorder. It's very, very common in the United States, 3% of the population. I think it's more now with Corona and staying at home. It also related to low dopamine in the reward system. So when some people might born with low dopamine in that area of the brain, and usually we compensate by overeating or using drugs. So all of these patients who are obese and overusing drugs or overusing food, they might have low dopamine in the reward system to begin with because dopamine is what make us happy. So we compensate by eating a lot to make us feel happy. Food, they look at food as an emotional, painful relation. So food is the way to comfort ourselves. Food is like stress will decrease dopamine. So when we are stressed out, we compensate by overeating. We call that emotional eater. So anybody who get any stress in her life, fail in exam or failed in relation or heard bad news or waiting for an exam to happen, they relieve the stress, which decrease their dopamine by eating a lot or smoking a lot. So smoking and eating is a way to raise that dopamine in the reward system in the brain. Complication of binge eating is obesity, type 2 diabetes, high cholesterol, all of this combination, and sleep apnea. Now, the difference between binge eating disorder and bulimia is binge eating, they are obese, they are overweight, and they don't have compensatory behavior. So they don't vomit and use laxative. So this is a difference between them. So no compensatory behavior. You remember bulimia, we said the same like binge eating. They eat, but then they go and vomit. But here they don't compensate. Just eat and gain weight. So they eat very rapidly. They eat when they are uncomfortable. Until they are uncomfortable, they eat when they are not hungry. So that's why Prophet said, نحن قوم لا نأكل حتى نجوع وإذا أكلنا لا نشبع. That's mean if we don't eat until we are really hungry, and if we eat, we will just eat a little bit, not too much. So DSM-5 is a recurrent episode of binge eating, at least occur once a week for 3 weeks, for 3 consecutive months, eating large amount of food in 2 hours, and having lack of self-control. Now it doesn't apply like if you are living in Riyadh and then you go on vacation like to Istanbul or Egypt or any place where they have great food there and you binge eat for like a couple of weeks and then you come back. I don't think that will be binge eating. It just that's a part of fun and having good life there when you go out of here on vacation. So but a lot of them will eat to avoid this feeling of emptiness because they feel empty. When you have low dopamine, you feel empty. Emptiness is low dopamine, so you compensate that by overeating, that feeling of emptiness. This is the way we learn how to deal with life. Sometimes it's part of self-loathing behavior. We hate ourselves and we attack ourselves by overeating. Sometimes we want to hide our emotion. Those patients try to hide their emotion and they don't want to be around people. And always they have some feeling and they want to escape that feeling by overeating. Usually, it is very common with ADHD, impulse control disorder, substance abuse disorder, and usually it's very common in those patients. Of course, we have to differentiate it from bulimia nervosa and anorexia nervosa, as we said in the difference. Treatment, there is a lot of treatment. This is the older treatment, 2012. So antidepressant might work. Buprenorphine or Wellbutrin, which we said is contraindication in bulimia. You can here use it very effectively because it might make you lose weight. Not a huge amount of weight loss, but few kilos. Uh, Sabutamine is also one of the medication we use, but it was removed from the market. Topiramate, Topamax is one of the medication, seizure medication that we use for weight loss. The problem with topiramate or Topamax, it make you forgetful. So if you take it, I gave it to one of my friend who is a doctor. He lost 40 kilos on topiramate. But the problem when he took the topiramate for 1 whole year, he couldn't work as a doctor. He sat at home and enjoy TV, because when you take topiramate at high dose, it will kill your cognition. You will not even remember your name. So the reason why you lose weight, because you forget to eat and you forget anything. Oral state is also one of the medication we use. Uh, Less dexamphetamine is a medication called Vyvanse. Vyvanse is a medication used for ADHD, but now it's approved for weight loss. Of course, the best treatment nowadays is bariatric surgery. I'm going to go quickly to the bariatric surgery, but before we go that, like there's now injection called, Victoza or Ozempic. This is part of medication they use to make the stomach full so you don't eat much. There is a combination medication now called propionate and naltrexone, propionate and zonisamide, topiramate and phentermine. So there is a lot of new medication for weight loss. There is an anti-opiate drugs. So sometimes if you increase opiate in the brain, you don't need to have food. So there is a lot of medication for weight loss nowadays, and it's a huge industry. But because but the best treatment so far is this sleeve or cutting part of your stomach, so your stomach will shrink, and it will be the size of golf ball. And the problem with these stomach, what you call sleeve surgery, is when we said food addiction is an addiction. So when you remove the addiction of food, most of these patients will become addicted to drugs and alcohol and shisha. So I have one of my patients who never smoked shisha in her life. After bariatric surgery, she lost like 40 kilogram, and she started using shisha 24 hours a day. So she compensate, or she replace food addiction with smoking addiction, or alcohol addiction, or addiction to drugs. So you need to monitor those patients very quickly or very carefully after the sleeve surgery. Remember, stress is one of the reasons why you overeat. Stress and lack of sleep is what cause you to have binge eating and cause you to have a lot of, you compensate. We said stress will decrease dopamine and decrease serotonin. And when you don't have serotonin and dopamine, you compensate by overeating. So always the binge eating cycle is related to stress and sleep. So remember, there is part of the brain called the Nicholas accumbens, and if you don't sleep well at night, next day you're gonna eat the walls. So you're gonna eat to compensate for lack of dopamine, which was not released during sleep because you did not sleep. So you remember, when you don't sleep well, next day you crave fat food. So this chocolate, you're gonna eat it in a skinny minute if you don't go to sleep. And most patients, when they don't sleep, they tend to crave fat and healthy food rather than crave my favorite strawberry. So they did a study in England. So they have 12 people. Six make them sleep very well, and six did not make them sleep well. They gave each one of them a 20 pound. They went to the supermarket. The people who slept well, they brought very healthy food unconsciously. And the people who did not sleep well, they brought a lot of fat and junk food to compensate for their lack of dopamine. And that's why the unconscious mind play a major role. Thank you very much. And if you have any question, please let me know. And let's see if there is any chat. So we do know drugs. We don't need to know the drugs in general. Just this is more for specialty. Okay. Thank you, doctor. Thank you, student. What should I say? I like you a lot.
Thank you, doctor, so much.
Thank you. Any question? Of course, if you have any question, please send me on WhatsApp. Any question you have, please feel free to send me to me on WhatsApp. And I'm glad you are liking my lectures. I'm very, very proud of you, student. And I hope we have a private Zoom session in the end so we can answer all of your questions. So I'm planning to have an 1 hour or 2 hours Zoom session with all of you to answer all of your question in general.
Thank you, doctor.
Thank you. I'll see you at 1 o'clock, Muhim.
Yes,